So, first of all, I want to thank Aris and all the scientific committee to invite me, and all the French college. You know, we have the biggest organization of fetal ultrasound, national fetal ultrasound in the world. It's mean we are the only country we are more than 3,000 physicians in ultrasound, and we have a college and we have a lot of paper, and I have the honor to be the president of this person, and in the name of all French college, thank you very much. So, to screen for fetal heart disease, we are trying now to have something very easy when we call ultrasound loop, and you will see that it's very, very easy to have a screening of CHD in this way to do. So, as you know, that congenital malformation is from 2 to 4% of all pregnancies, and the most often malformation are the heart disease, congenital heart disease. In international publication, it's between 0.6 and 1.3%. In Eurocate, it's about 0.62. EPICAR is a French study who gives 0.9. So you see, it's always about 1%. And usually it's an accident. It's mean that you have to have a screening because more than 85% of heart malformation are in a non-special population. It's an accident for someone who have no family history and no problem. So it's especially in low population, but you have a high risk population of heart disease, especially if the NT is more than 85%, and this is what Professor Antsaklis say this morning. Even if you have an IEPT, we have always to have the first trimester scan to see the IT, because the NT is very important to screen after for heart malformation. Family history also. If you have a family history of one heart disease, it raises the risk from 1 to 3%, and if you have two, it raises from 8 to 10%. If you have two children with a heart malformation, even if you don't have any dilation of 22 or Georges syndrome, you have 10% the risk of recurrence. And also if you have teratogenic, for example, like lithium, like alcohol, like lupus, and like phenylcetonuria, diabetes or Ribella, so you have more risk of heart malformation, heart disease. So why to do screening? Why this subject today? So to explain, I have just a paper from Damien Monet. It's from 1999. He took 250 transposition of the great artery, and he took the prenatal diagnosis to compare with postnatal diagnosis. As we see, the time of admission in a cardiac unity, when the diagnosis was done before delivery, was 2 hours. If the diagnosis have been done after, 73 hours to go to the cardiac unit. The pre-surgery mortality was 0% when we have a prenatal diagnosis, and 6% when it was a postnatal diagnosis. The post-surgery mortality was 0% for prenatal diagnosis and 8.5% when the diagnosis was have done after delivery. So you see that it's about 15% of mortality pre or post-surgery when the diagnosis is not done in prenatal. So this is explain why we have to do this detection of heart disease. Also, for chromosomal anomalies, you have a lot of chromosomal anomalies when you have a heart disease. Detection of all polymalformation, genetics or not genetics. Associated anomaly, you see, if 30% of heart disease are not isolated, you have to find something else. You have to see other places to see if there is anything else. I would not like to do a lot of embryology, just to show you two things. The first thing is the auricular fold. You see, this is the primum ostium, primum ostium of auricular, and this is secundum in left. And just to see that the two holes in the primum and the second ostium, the disposition is that the blood coming from ductus venosus, from umbilical vein and ductus venosus, will come to the right auricular and go immediately to left auricular to have the oxygen blood. And this is why we have these two holes, and this is why we have the foramen ovale on this position. The other thing of embryology is to see that the conotroncus and the ventricle is very, very, very close. This is just an illustration how it works. And every time I explain this to the student, I say this is why on the base you have the fourth chamber, because the auricular and the ventricle are lying on here on the diaphragm. And especially, what I want to show you, I use it always with a bottle of water. I take the bottle of water like this, and I say, look, you have the ventricle, and you have your two fingers are the pulmonary artery and the aorta. And when you put this on your bottle, you have to turn 180 degrees. And if you turn 180 degrees, there is no water fall. But if you turn 150, you will have water will come by here. If you turn 90 degrees, it will mean more. And if you don't turn a lot at all water will go on. And this is the explication of what's happening between the vessels, the great artery, and the ventricle. It turns like this, and when it don't turn, you have conotroncus anomalies. It could be just fallow disease or interruption of aortic arch. You have all the spectrum. It depends of turning the bottle. So you have, this is for artery, and just very quickly, this is for vein, and you see the ductus venosus coming here and going to the inferior cave vein. So, in fact, this is a heart. You have right auricle, left auricle, right ventricle, left ventricle, pulmonary artery, aorta. Between right and left auricular, you have the foramen ovale, and between pulmonary artery and aorta, you have the ductus arteriosus. This is very easy. In fact, this is the heart. This is like this. So you have to understand this position, and usually we said before that this is the 4D chamber view, and this is the three vessels view. You see, this is the heart, what we see. So, in France, we decided in 2005, to have 5 items for heart. But these 5 items, just 5 items, but you have to have them always, all exams. And if you have just 1 item less, you have to ask for diagnosis ultrasound. The screening is you have always these 5 items. I will discuss them. And in the beginning, we ask for 2 images, the 4 cavity views and the short axis. And then in 2016, we changed a little bit. We still need just these 5 items. And I put also the stomach in these items. And now we have 13 images to give, but 3 from the heart, 3 images heart, 4 chambers view, the continuing between left ventricle and aorta, and the pulmonary artery with the separation. You have, for all screening in France, you have to have this 3 images. If you don't have these 3 images, you have to ask for diagnosis exam. So how to obtain this? This is a slide from Rabbi Shawi several years ago, and he said that the best thing is to go from stomach to 4 chambers view, to left ventricle aorta, and to right ventricle pulmonary artery. And it's exactly when you go to the hotel, you have the -1, the parking. The parking is the stomach. The ground floor, the reception, the lobby is the 4 chambers view. The left ventricle to aorta is the first. So, but if you have to have the aorta have to go to the right. So if the aorta goes to the right, the door have to open on the left. And in the second place, if the pulmonary artery have to go to the left to go to the situs arteriosus, the door have to open to the right. You will see what I'm saying about. So you begin by stomach, 4 chambers view, left ventricle aorta, right ventricle pulmonary artery, 3 vessels view. So you can do it like this, and you can use the color. And when you have this, 100% of malformation, you can see 100% of heart disease. So several persons present this also. Hegel have discussed this thing, and now in France we all do this lift from -1 to the so the five items in France. The first item is the frequency of heart rate. It has to be between 120 and 180. So you can look it here, like you can register here by TM. You can see here TM that you have atrial perimeter beam. It's often at 22 weeks. Also, this blocked arterial perimeter wheel is very often, but this is not very often. This is a supraventricular tachycardia, and this is an emergency. If you see this, you have to take in charge. You have to have a treatment, because on this stage you can use just digoxin. If it goes more, you have to use more drugs. This is more. You see, this is the same thing, but you have here a pleural effusion. And now you cannot just use digoxin, you have to use several drugs to reduce this supraventricular tachycardia. As you see here, it's more than 289 beats per minute. Also, you have also bradycardia by atrioventricular block. You have to search an autoimmune anomalies on the mother. The second point is the heart position. You have always the apex of the heart on the left of the baby. So you have always to know where the right and then the left. So if here the baby is like here, so it's normal. The left is here and the right is here. But if you have the baby like this is not normal at all. This is a situs inversus, because the right is here and the left is here. And this is very easy. I will show you something. This is very easy. Look, when you have the 4-chamber view and you have the line from here to here, you have the apex 45 degrees with this line, and especially the volume of the heart is 1/3 of the thorax, and 1/3 of the heart is on the right, and 2/3 of the heart is on the left. This is easy. It's very easy. 1/3, 2/3, and the heart is 1/3 of the thorax. And 45 degrees for the angle between this X and this X. And look, you see here always, when we have this line, the aorta, the descent aorta, is on the left. And you can see the same thing if you go to the parking, -1, you see that the aorta is on the left and also the stomach is on the left. So you have to always to go from reception, from the lobby to the -1 to see if it's okay, you are on the left or not. So this is situs inversus. This is some pathology. You see here that this is a breech presentation, and the left is here, the right is here, the apex of the heart is here. Immediately you say there is something wrong in this heart, even before to see the great arteries or the ventricle or anything and see the volume, you see, if there is a problem, the apex is on the right and not on the left. Okay, dextrocardia. You see here that if you have the line here, you have all the heart on the right, because this is a cephalic presentation, so this is a diaphragmatic hernia for sure, and it is a left ventricle diaphragmatic hernia. This is the same thing. So it's very important to know the right of the left of the baby for the heart. This is a CCAM. You have the heart here. You have the normal pulmonary and the huge pulmonary here, signing a CCAM left lung. This is also, you have a normal pulmonary area here. This is the right, this is the left, this is the right pulmonary. The heart is here. So the problem is that we have an atresia of left main bronchus. Also here you have the right, the left, all the heart is here. This is a normal pulmonary area, and here there is no pulmonary. This is for sure an agenesia of left lung. Third thing, the four chambers view. This four chambers view is very important. You have to have a segmental analysis step by step. It means that you have to say, this is left ventricle. The left ventricle have to send blood to all, even if on your feet, all your life. So the left ventricle have to be very strong and very long. The right ventricle have to send blood just to pulmonary by the pulmonary artery. So you have to have trabeculation, because if we have the same ventricle on the right, you will have hypertension on the pulmonary artery. So this is why you have difference between left and right ventricle. The same thing for auricular. The auricular here, the right auricular, you have just three veins coming in the cave. The inferior vein cave, the superior, and the coronary vein. So this is what is round. But the left auricular, you have the four pulmonary vein. So this is why you have angles, and you have what we say the buffalo head on this auricular. So you have to have a segmental analysis step by step for this all four cavity, and to see that the aorta is also on the left. Same thing for another one. The four items is the four chambers view balance 2 by 2. It means that the right atrium have to be the same thing as the left, and the left ventricle here like the right ventricle. For example, here you can see that there is a problem. So this is a left heart hypoplasia. This is the right heart, the right ventricle, excuse me, and the right atrium. You see the little aorta and the huge pulmonary artery. Okay, this is the same thing. This is the left auricle, left ventricle, right auricle, and right ventricle. You can see this is aortical stenosis with a left auricle dilatation. This is you see here the blue color. It's the tricuspid regurgitation. Why you have tricuspid regurgitation? You have to think that perhaps there is a problem on the pulmonary artery, and you have to see if the pulmonary artery is normal. So you see here, this is an Epstein. Excuse me. This is the same thing, 2 weeks after, and you see here is the stenosis of pulmonary artery. Oh, atresia, not aresia, atresia, excuse me. Here you have difference between the two ventricles. This is the left one. You see that the left one is very, there is asymmetric, is less than the right one. You see, the left atrium is less than the right atrium. So it was here the pulmonary artery, the aorta, and the superior vein cave, not inferior but superior. So it was a coarctation of aorta. Here it's the same thing. It's atresia. So also, as I explained to you, to open the door on the right or to open the door on the left. Here you have the four chambers view. When you go on the first floor, you have to think that the first artery leaving the heart is the aorta. And it have to open to the right. So the direction of the aorta have to be on the right. The second floor, you have to open on the left, and the direction of pulmonary artery is on the left. You have to open on the right. So you see here, I can just after. So look, this is four chambers view. I'm going to the first floor. The door is opening on the left, and the aorta is going on the right. This is the second floor. I'm going to the second floor. The door will open on the left, and pulmonary artery is going to the ductus arteriosus on the left. It's opening on the right and should go on the left. Okay, you have to see which the direction of aorta and pulmonary artery. Okay, so here you see aorta, and we go another one, the aorta. It's always going from the posterior ventricle. This is pulmonary artery. You see, this is a division between left and right pulmonary artery, and this is division between the ductus arteriosus and right pulmonary artery. This is the ductus arteriosus coming from the anterior ventricle. So when you see this, you do the diagnosis. This is a overlap aorta. This is a fallow disease. This one is transposition of great arteries. You see here, left ventricle, pulmonary artery, because there is a division here. You see the division, so this is a transposition of great arteries. Here, you see, left ventricle, this artery, division, this is pulmonary, and this is aorta. And you see it's double here. See here, up, you see, division, pulmonary artery, and left ventricle and pulmonary artery. This is left, the apex, left ventricle, right ventricle, and double outlet. But even if you have double outlet, you have a transposition of great artery. All the two are leaving the right ventricle, but you have a double malformation. So this is the tricuspid you have seen just before. So in very near future, you can use all what I show you in the first trimester, as we explained just before. You can see here, this is first trimester view. We have done a study in France. 86% of patients, we can see the four chambers view and the three vessels view by 2D, but especially by color in first trimester. So I think this will be the future at the exploration of heart. I show you here very quickly tricuspid atresia, a mitral atresia. This is a atrioseptal defect, Epstein disease, and this is a tricuspid problem. This is, look here, aortic coarctation at 14 weeks. Okay, so conclusion: the items have to be what we discussed just on the pause on the coffee break. you have to have a screening. You have to have a sign that everybody can do. And really, the 5 items I show you, you can do it for everybody. If you cannot, you have to ask for diagnosis ultrasound scan. So it has to be simple and reproducible. And the challenge here is research for lethal and incurable defects, follow up for high risk of neonatal heart malformation, and call signs for gene or chromosomal anomalies. And this is all my team in the French College who helped me to do these images. Thank you very much.